Okay, hi everyone. Thank you for joining us this evening. Today's tutorial is on multiple sclerosis given by Minnie. Just a couple of rules before we begin. For those of you watching via Zoom, if you have any questions, just pop them into the chat or the Q&A. If you're watching on the Facebook Live, just comment your questions and we'll make sure that they're passed on. That's all from me, and I'll hand over to Minnie to begin. Thank you.
Hey guys, I'm Minnie and I'm just going to be going through MS today. Okay, so these are the learning outcomes. Essentially, we're going to go through like what MS is, the risk factors, symptoms and signs, then investigations and treatments. So to start off with, for the background, what is MS? So MS is basically an inflammatory demyelinating condition of the central nervous system, and it is autoimmune. The whole disseminated in space and time thing just basically means that clinically a person has to have two separate episodes, which are separate in space, so basically in two different areas and also at different times. And when they say different times, they just mean like a month apart. And generally people usually get like attacks every 1 or 2 years. And because of that, MS is actually quite difficult to pick up. With the epidemiology, MS classically presents itself in white women around the age of 20 to 40 years in the UK. However, it could generally affect anyone, any sex, any age, any ethnic group, because 2.8 million people have it around the world, and like 1 in 300 adults are like every 1 in 300 adults have it, and every 5 minutes someone is diagnosed with MS. And it's important to note that it's not just adults that can get it, but even like 300,000 children or teens are said to have MS globally. This is just like a map we were shown like in one of our lectures, and I thought it was really good. It just shows the whole prevalence of MS around the world. And as you can see, there's like places where it's much more common, like the darker reds. Okay, so the different types. There are 4 main types of MS. One of them is relapsing remitting MS. So this basically means that you have unpredictable attacks known as relapses. And these are usually followed by like months or years of remission. So not seeing any signs, no signs or symptoms during this time, the period of remission. And most people with MS have this relapsing remitting type. And the attacks are usually short duration, so they last like around days to weeks. Then we have primary progressive MS, and this basically means that people never get this remission period. So after their initial MS symptom, they just carry on progressing. And this type of MS is really difficult to treat, and we'll come on to that later on. And about 10 to 15% of cases, and this is seen in about 10 to 15% of cases. Then there's secondary progressive MS, which essentially is when it starts off as relapsing, but then eventually you would have a progressive decline. And this happens when during the progressive decline, again, no remission periods. And this basically happens in about 65% of people. And 85% of people with relapsing remitting MS will eventually progress to secondary progressive. And then the final one is like progressive relapsing. So essentially this is when people have a very steady decline, but also have very distinctive attacks. And this type is really, really rare. And yeah, this is just like a table that summarizes all of that. And these graphs, I think, show them quite well. So MS was classically viewed as a disease of the white matter, but now there's evidence that both the white and grey matter are involved. So the number of lesions in the white matter does not really correlate to the severity of the disease. However, with the grey matter, the size and the lesions of the grey matter actually does correlate. So more and more we're finding out that grey matter is actually really, really involved in this. And MS basically it both the inflammatory and degenerative like components to it, and this can be triggered by environmental factors, which are seen on which I'll go through on the next page, or people usually have like a genetic they're usually like genetically, there's a genetic component to it, and this is said to be about like contributing about 30%. So if, let's say, your first degree relative does have MS, you are around 20 to 40% more likely to have it as well. On the genetic specifics, this is usually found on HLA chromosome 6. So in specific, HLA DR15 and DR16 are said to be very like associated with MS. And this specific allele over here, so HLA DRB1 15.01, that is said to increase the risk the most. This allele over here is said to be associated with like protection from the disease. And then other things that are associated genetically with it are the IL-7 receptor alpha and IL-2 receptor alpha. Okay, so risk factors. With risk factors, the main one I would say that is known the best is vitamin D deficiency. So with people that have increased UV radiation, they are said to have a decreased risk of MS. So increasing the vitamin D levels, especially before a particular age of like 20 years, is said to be associated with a decreased risk of MS later on in life. And this has been further like supported by by migration studies as well. And also people in a higher like the northern latitude are more at risk of developing MS. So this is basically the strongest link so far. The other link that's possible that they have seen in studies and stuff is obesity, especially earlier on in life. Some studies have shown that night shift could contribute to it, but there's not really enough data on that. Some other studies have shown that the gut bacteria could also take place and take part in like activating the immune cells to attack the CNS. However, again, the research about this is very lacking. Smoking tobacco is also said to be one of the risk factors of MS. So this is said to be in a very dose-response relationship. And they think it's due to like non-specific lung irritation, because oral tobacco doesn't really increase the risk of MS like smoking tobacco does. And essentially they think what could potentially be happening is that CNS autoantigen cells are present in the lungs, and these cells could be activated and then they could eventually go and attack the CNS. But again, it's just very like, they don't really know that much at the moment about that either. Then we also have exposure to infectious agents. So the one that they have found the biggest link with is EBV. So EBV usually resides latent in B cells, and therefore anti-CD20 treatments that basically deplete these cells have been really successful in treating MS. Furthermore, those people with EBV and like infectious mononucleosis are said to have an even higher incidence of MS than those with just EBV. So that's just proving, like, supporting the fact that EBV has a strong link to MS. Again, with women, because they are more likely to with epidemiology studies, they've shown that women are, there's more prevalence of MS in women. That's why they think that hormones might have a role over here. However, they're not 100% sure, like there's just not enough evidence currently to be certain about that. With the pathophysiology, a lot of it, again, is quite unknown, like with the risk factors. They don't really know whether there's a specific or sensitive antigen or antibody. There's some debate about MS, even like if it's one disease, or whether it's like a syndrome of like subgroups that they've kind of just clumped together. It's just a bit unknown. However, what they do know is that inflammation and demyelination happens, and then this can be followed by axonal loss and neurodegeneration. So with the inflammation and the demyelination, what basically happens is that inflammatory cells, they release antibodies and cytotoxic mediators, which can then damage the myelin. So at this point, once the myelin is damaged, electrical signals start leaking out and fading away. And because of this, the axons become more vulnerable to damage. They said that the main thing that like kicks all of this off is your CD8 positive cytotoxic T cells, just basically starting everything. However, the actual degradation of the myelin sheath is said to be mainly by your macrophages. And at this stage, it can be reversible, so the symptoms and stuff, they can subside. However, as soon as they start getting axonal loss, which can lead to neurodegeneration, at that point it's irreversible. So the reason why I can go from here to here is because the demyelination disrupts the axonal support, and this basically leads to destabilization of the axonal membrane potential. And then essentially and also they say that inflammatory cells, antibodies and complement may also contribute to the axonal injury. And as soon as the axon is like injured, then it will lead to neurodegeneration. With this stage, some of this can be remyelinated. So after the axons are demyelinated, some like protection can happen. However, the sheaths when they are remyelinating is usually thinner. And this is more like extensive at the start of MS, but then later on, as oligodendrocytes die, so oligodendrocytes are the ones that are basically myelinating in the CNS. Once they start dying or there is increased damage, later on as MS progresses, there's less and less remyelination occurring. And there's loads of reasons that this could fail, from things like maybe the oligodendrocytes precursors aren't proliferating properly. It could also be that the myelin is not forming because it just can't sense the oligodendrocytes are there. They might not be migrating to the lesion. There's loads of like possibilities about why this might happen, and none of it is like confirmed at this current point in time. Okay, so this is the first question. Which of these are not a type of MS? I'm just gonna launch the poll. You guys should be able to vote now. Okay, I think most of you have voted. So I'm gonna share results. Okay, so yeah, most of you got that right. It is chronic relapsing. That's not a type of MS. The others are a type, and it's shown over here. I saw a question saying, what exactly does the genetic component mean? The 30% mean, it just means, like, by that I meant that basically they think in about 30% of patients there can be a genetic component also involved. However, with that exact amount and stuff, it's again like they're constantly finding new and new data with it. So because of that, I'm pretty sure it's likely to change later on as well. Okay, so here's another question. Which of these cells are predominantly involved in the degradation of the myelin sheath and MS? You guys should be able to vote now. Okay, I'm gonna end it there. Okay, so some of you got that one right. Okay, but so the CD8 T lymphocytes, essentially they do kickstart everything, and MS is known as like a T cell mediated autoimmune disease. However, the actual cells involved in the myelin sheath, like actually like degrading it, is the macrophages. Recently they found with loads of studies and stuff that it's actually the macrophages that are found in the plaques around the myelin sheath being degraded and stuff. But that was quite a hard question, to be fair. Okay, so the symptoms and signs. With MS, it could like present in loads of different ways. And over here, I'm gonna like go through relapsing remitting MS in specific. So these symptoms, for it to be considered, like even slightly considered as MS, they should last longer than 24 hours. And essentially with relapsing remitting MS, they happen as distinct episodes, which are separated by at least a month. And an important thing to note is that everyone might not present with all of these symptoms. So the main symptoms do include things like fatigue. They may have difficulty walking. They may have vision problems, and vision problems are said to be the most common symptom that can arise in relapsing remitting MS. So vision problems would include things like blurred vision, optic neuritis, unilateral when vision in one eye deteriorates, or like pain in eye movement, rapid loss of central vision. They could also have problems in controlling their bladder. They could have numbness or tingling. They may have muscle stiffness or spasms and cramping, or general just weakness. They might have problems with balance and coordination, diplopia, dysarthria, tremor, problems with like thinking, learning, planning. Basically, it can just present in a really huge range of symptoms. And there are also two signs that could be seen. So one of the signs are known as Lermit signs. So basically when you have like sudden flexion of the neck, this is then causes like electric shock sensations in the limbs. So as soon as you flex their neck, they'll feel this sort of electric shock feeling across their hands and feet. The other phenomenon is that the symptoms get worse after they exercise or when they're in a warm environment. For example, after they've taken a bath, they may find that their symptoms or a hot shower, they may find that their symptoms have got worse. The important things to cover in a history, other than like asking them about their presenting complaint, would be the past medical history. So you want to make sure if they've had any history of focal neurological deficits or any other autoimmune diseases. You want to check if they have a family history of MS or any other autoimmune diseases again. You want to check if they smoke, how their diet is like, and also how this symptom is affecting their daily life, whether they drive, because if they have problems with vision, is this something you have to like ask them to contact the DVLA about? And also you want to do like a falls risk assessment just to ensure that they are safe when they're walking around and inside their house. During the neuro exam, a fundoscopy would be performed to view the optic disc. You would also do like the swinging flashlight test to see if there's any afferent pupillary defect. You would notice their eye movements, especially on the neuro exam, just to see if there's any like ophthalmoplegia, if there's any other like, if their affected eye may show like problems with adduction, perhaps. You want to check for like facial paresthesia, so like if the trigeminal nerve is involved, and you also want to see if there's any nystagmus. With progressive MS, so like a few slides previously, I said that MS usually presents between like 20s to 40s, white, female. With progressive MS, the age of onset is slightly later on average. So progressive MS usually presents around like when they're in their 40s to 50s. And at the start, what it could happen would just be like stiffness and weakness in both legs. So they could be tripping on curbs or tripping when they go upstairs. However, eventually it could lead to paralysis. However, an important point to note is that progression can vary from person to person, and not everyone would progress really quickly from here to here. Some people, they may not even go to the point that they are paralyzed. It might just be severe weakness and stiffness in their muscles. It just varies a lot, basically. People with progressive MS also have bladder and bowel problems and sexual difficulties, and they also experience a lot of fatigue. And by fatigue over here, I just mean just extreme exhaustion. So for any activity, how tired they feel is completely out of proportion compared to someone else without MS. Also, symptoms with MS, they usually vary from day to day. It's really, really unpredictable. Okay, so this is a type of SBA question that you could be asked. A 48-year-old female presents to the GP with a tingling sensation in her hands for the past few weeks. She also complains of fatigue for the past few months, which has been getting increasingly worse. She has diabetes, for which she takes metformin. However, there's no relevant family history. What is the most likely diagnosis? I don't know where the poll thing. Let me just open up the poll 1 second. Okay, there you go. Okay, just a few more seconds. Right, okay. So that, unfortunately, a lot of people said primary progressive MS, and yes, I know it does seem like it, but the one person that said vitamin B12 deficiency, well done, that was correct. And I know this is an MS lecture, so that was really peak, but it was just to show that essentially MS, the symptoms of this can present in loads of different ways, and loads of other conditions or pathologies can mimic MS. So it's really easy to misdiagnose it as well. With this one, the reason why the most likely is vitamin B12 deficiency is because this patient is diabetic. So that's one risk factor. They have tingling and tiredness, which all basically point towards progressive B12. And no, so the reason why it's not relapsing remitting MS is because no other symptom has been mentioned at this current point in time. You're not really like, so they said they had the tingling sensation, but that's just one episode that they've described over here. There hasn't been any description of any other episode over here as such. So it's not likely to be this one. With this, potentially it could be progressive because it has said that it's been getting increasingly worse. However, usually with progressive, they, in SBAs at least, they would usually do things like muscle weakness, and they would usually have bladder symptoms also there. There would also be like risk factors, like they would be like the family has a history of autoimmune diseases, it would just be more obvious in an SBA question if it is primary progressive MS. Stroke is not acute enough for this to be it. And neuropathy, yes, potentially this could be neuropathy. However, because of the fact that she is diabetic and the fatigue and this tingling sensations, it just points towards vitamin B12 deficiency a lot more. Okay, so the management. So to start off with, we're going to look at the investigations. So you first want to check the labs, and you want to do this to exclude any symptoms or any conditions that could potentially mimic MS, for example, the vitamin B12. So you want to do a full blood count to check if it could be an infection. You want to do the CRP, you want to do LFTs. LFTs are just done for like baseline biochemistry to rule out any like hepatic pathology which could be associated with MS. However, the main ones I would be like are your urea and electrolytes, because loads of electrolyte disturbances can mimic MS symptoms. You want to also do calcium and angiotensin converting enzyme to rule out like sarcoidosis. You want to do TFTs to rule out hypothyroidism. Vitamin B12, you want to test for that to rule out like any other causes of like peripheral neuropathies. And they would also do like an HIV serology to rule out HIV. The radiological tests that can be conducted include your FLAIR MRI. So that's an example of a patient with MS, and this is an MRI. So can you see that over here, there's like these bright spots over here? Those are known as like hyperintensities, and they are usually found within the white matter on the MRI. It's a lot easier to see. And basically the reason why you do a FLAIR MRI is because it's like the type 2 of an MRI, and it corrects for any CSF movements which could potentially affect the signal on the image. However, with MRIs, the issue is it doesn't really pick up grey matter lesions, which is why for so long they thought MS was only something to do with the white matter. However, later on, they found out it's actually also to do with grey matter as well. In the notes bit in the PowerPoint, I do have a bit more information about why these lesions come up, but because of time, I don't think I will have enough time to go through at the moment. They also do a lumbar puncture, and the lumbar puncture is essentially just to analyze the CSF. So this is usually done if there's no like clear radiological evidence of white matter pathology of MS. And if there's oligoclonal bands present, at that point, they're like, okay, this is very likely to be MS. And essentially, the lumbar puncture would show increased protein, so in specific gamma globulins, which are products of activated B cells in the CNS. And usually when they do this CSF, checking for the CSF electrophoresis, they also do a serum electrophoresis to compare both of them at the same time. Okay, so the whole disseminated in time and space came from the McDonald diagnostic criteria, and essentially is just saying that events have to happen in more than one distinct time period, and they also have to have like in two completely different locations for it to be called MS. So let's say that the patient has clinical symptoms that are shown to be disseminated in time and space. At that point, you can be like, okay, this is very likely it can be MS. And you don't really, at that point, need to do an MRI as well. However, it's usually just done as supporting evidence. But according to this criteria, at that point, you would be like, okay, yeah, this is likely to be MS. Let's say the clinical symptom shows dissemination in time, but not in space. So at that point, we would either need to wait until it shows a dissemination in space, or we can, so basically waiting for another clinical attack at another site, Or we can do an MRI, and if that shows dissemination in space, at that point you can be like, okay, this could be MS. Let's say the patient has one attack, which causes two different symptoms. So at that point, you want to wait to see if they have a dissemination in time. So wait for another clinical attack. Or you could do a MRI to show that there could be a dissemination in time. So doing a scan later on that shows that there is new lesions would show this dissemination in time. Or if there's like oligoclonal bands present in the CSF, this also ticks off that criteria. Then let's say a person has one attack, it's just that one symptom. At that point, clinically speaking, you need a lot more of your diagnostic evidence to back it up that this is MS. So you would need to do an MRI, which shows dissemination in time and space, or there needs to be like oligoclonal bands in the CSF. So all of that is basically summarized in this table over here. And yeah, I got that table from Geeky Medics. So the management targets. So a patient with MS, you want to try and suppress their relapses and prevent like disease progression. And radiologically, you want to prevent new white matter lesions and reduce the rate of brain atrophy. So let's say someone has an acute episode. So nice guidelines on what an attack is basically new symptoms or worsening of existing symptoms, which has a subacute onset, so greater than 24 hours, with an absence of any signs of fever and active infection, basically. And you want to make sure there's no other illness or infection happening at the same time, because usually patients with MS, they commonly experience worsening of their symptoms during like infections such as a UTI, sinusitis, viral infection, cellulitis. So therefore, any underlying infections should be treated appropriately before you decide to manage their acute episodes with other means or methods. And another important point to note is that not all relapses require a medical intervention. So sometimes if you just leave the relapse on their own, like this, the symptoms might just go away. However, let's say the relapse is affecting the function. So they have difficulty like using their hand, they are experiencing really bad coordination or weakness problems. At that point, you would give them high dose methylprednisolone. And so this would be about 500 milligrams orally for 5 days, or 1 gram orally for 3 to 5 days. And these patients can be managed in the community by their GP. However, let's say for some reason the severity of the symptoms aren't being managed properly by the methylprednisolone, at that point they can be referred to the hospital. And if, let's say, it is refractory to steroids, so it's not working, at that point they would consider plasmapheresis as an option. And plasmapheresis is basically just when they remove and exchange the blood and then put the new and like treated blood back into the body. Flares, like I mentioned, flares of MS, they can be caused by an infection. So the main thing that you have to do is rule out the infection first. And then at that point, you would consider the methylprednisolone and the plasmapheresis. So that was acute management. With the long-term management, currently, unfortunately, there's no therapies which can cure MS. However, there are loads of disease-modifying agents, and these are the most common examples that I've included over here. So the first one, this one, beta interferon and glutamate acetate, these are known as your injectables. And basically that's because you can inject them into the body, and they are inflammatory, they regulate the response, and what they do is they just reduce the relapse rate, and they slow down the accumulation of disability. And these ones are good because not many side effects are seen. However, this isn't the strongest type of disease modifying agent that can be used. There's a lot of other agents that are better than this. With the dimethyl fumarate, this is very well tolerated. However, some of the treatments have been linked with leukoencephalopathy. Phylingemoid is again very effective. However, the side effects are bad. So it can cause symptomatic bradycardia or conduction block, which happens in about 2% of patients. Cladribine, this reduces relapse rate really well. However, it only does this for the first 2 years. And after that, it doesn't really cause much of an effect clinically. So therefore, if they were given this disease modifying agent, they would only be given it for the first 2 years. And over here, we have your monoclonal antibodies. So these ones, the natalizumab and the alemabtaz, that is basically, they are very, very effective. However, they are associated with severe autoimmune related adverse effects. So for example, they may have this multifocal leukoencephalopathy. They might also have loads of adverse infections, and essentially that's why they're not really that preferred. However, they are so effective, like they will definitely reduce the relapse rate significantly. More recently, these ones have been used. So this specific one, so your ocrelizumab, that has been shown to slow progression in patients with even primary progressive MS. So this is the only one that's currently approved for treating primary MS. And then we have siponimod, which is really useful for secondary progressive MS. But let's say all of these disease modifying agents, for some reason, they don't work. At that point, you would consider doing a stem cell transplant. However, this is associated with a lot of side effects, as you can imagine. But it is shown to be really, really effective. In general, to summarize this bit, usually more effective drugs, they have an increased risk of side effects. And the decision of when and how to treat patients really relies on the disease characteristics, the preferences of the patients, the neurologists. And historically, injectables were given as a first-line approach. However, recently studies have shown that the stronger agents, so like your monoclonal antibodies, they are better to start them off like at the very beginning with them, as it's been shown to improve the disease progression a lot more than if they're started off later on. However, you do want to tailor it towards the patient. So for example, let's say a young female with a mild disease, so a very low relapse rate, comes in and she wants to be pregnant. At that point, you wouldn't really want to give these sort of really like intense drugs. You would want to give something a bit more lighter. So like you would want to start off with the injectable therapy, because that would still provide a reasonable chance of like curbing the disease. However, it also has the good safety profile. So it's very much dependent on the situation with these. With the other drugs that are involved with long-term management, is that you also want to manage their modifiable risk factors. So you want to stop them from smoking. You want to like target their, if they're obese, you want to try and like target that. You want to target the vitamin D levels as well by making sure that's normal, and also ensuring all immunizations are up to date. And then we have the symptomatic management. So let's say they have immense fatigue, you want to refer them for physio and exercise therapy. If they have balance issues, again, you want to refer them to physio. However, if let's say physio is not really helping that much, you might also consider giving famotidine. So this basically is given in patients to increase our walking speed. If they have spasticity, again, physio is the main one, but they might also be given antispasmodic medications such as baclofen, or they could also be given botulism toxin injection at the affected muscle sites. If they have bladder or bowel issues, catheterizing, laxatives, and anticholinergic medications are those sort of symptomatic management treatments for that. Okay, so this was just from like a paper. It just said what they thought were the treatment recommendation. However, like I went through right now, it really depends on the patient. It's very much you want to target towards the patient. And the prognosis of people diagnosed with MS is not that great. So most of them do become unemployed within the following 15 years. 50% of the patients do require some form of mobility aid within like 20 years of their diagnosis. Half the patients will eventually develop substantial cognitive deficits, and there's a reduction in life expectancy of 7 to 14 years. And with primary progressive MS and a later age of onset is associated with a shorter survival. Other things that could indicate a worse prognosis would be things like the fact if they're male, if they have prominent cerebellar involvement, if there's frequent early attacks, or there's like rapid development of fixed disability. All of that could be associated with worse prognosis. However, these two are the main ones to be wary of. Okay, so you are suspecting a patient has MS. She has come to the GP practice with tingling sensation in her hands. Furthermore, she presents with optic neuritis 3 years ago. Which one of the following options is needed in order, according to the McDonald diagnostic criteria, to diagnose the patient with MS? Let me just get the polling open. Okay, you guys should be able to vote now. Okay, I'll just give a few more seconds. Right. So, okay, this was quite a hard one again. Sorry, I'm giving really, really difficult ones. But basically, yes, an MRI showing dissemination in time and space would definitely help with like help you like support the diagnosis. However, it's not actually needed. So at this point, the two people that said that clinical evidence is sufficient, that is correct. So if this patient over here, they presented with tingling, so that's, and then afterwards they also had optic neuritis. So can you see how there's two completely different areas that are affected? So that is the dissemination in space done. The fact that the optic neuritis was 3 years ago, and there's a new symptom now that shows that there's dissemination in time as well. So clinically, the symptoms have shown dissemination in time and space. So therefore, you don't really need an MRI according to this criteria to like confirm it, because at this point, the diagnosis is already confirmed. However, doing an MRI is always good practice. So they would still do an MRI just like as supporting evidence about it. Okay, so the next question is, which one of these following disease modifying agents is FDA approved for progressive MS? This one's also quite hard because there's a lot of drugs that we went through. Okay, I'd give it a few more seconds. Ooh. Okay, so I'm going to end it there. So, yes, most of you did actually get that one right. So with this, it is this one that is being approved, and that's the only one that has been approved for progressive MS. The other ones, they have been approved for relapsing remitting MS. And this over here just shows like when each of them have got approved and for what. So the RRMS is relapsing one. Over here, that's for progressive, and recently this year, we've have something approved for the secondary progressive MS as well. Okay, so basically MS, it is an autoimmune inflammatory condition which causes demyelination of the CNS. The presentation can be really varied, so it could be anything from like vision problems, limb numbness or tingling, limb weakness, anything basically. The McDonald criteria mainly revolves around the whole fact that it has to be disseminated in time and space. Acute management is usually if, let's say, is quite severe, at that point they would be given high dose steroid therapy. And long-term management, basically injectables, you have your monoclonal antibodies. There's also symptomatic treatment, which is targeted as well. This is where I got all the information from, and that is a feedback form. I don't know if there's any bits that you guys want me to go through again, because it is quite complicated. Can't remember if you explicitly covered differential diagnosis during the presentation. Oh, okay. So the differential diagnosis for this, there's actually so many. So if I go back to the investigation slide, because at that point I briefly touched upon it, you want to rule out any vitamin B12, that's one of the main differential diagnoses for this. You want to also rule out any other electrolyte abnormalities, for example, like hyponatremia, etc. Hypothyroidism is another differential diagnosis for this MS. There's other like neuropathies that you want to rule out as well, because if they just present with tingling, it could quite easily be that. Essentially, the differential diagnosis, it depends on how the patient presents, because people can present in such a variety of ways. It kind of varies, but those are just a few of the main ones that you would want to definitely rule out. I hope that's helped.